Good morning, everyone. I would like to thank AIOS for giving this opportunity. Today, I'm going to discuss on our experience with the magnificent IOL. Now, we have a lot of EDOF or presbyopic IOLs in the market, and one of the new IOLs or relatively new IOL in the market is the magnificent IOL. Basically, it is more of an enhanced monofocal IOL, where it converts the point focus into an extended focus. That's why you get that extended depth kind of vision. So the uniqueness about this particular IOL, it had these patented material technology which reduces the visual disturbance and also has higher modular transfer function. It's made of a material which is grisling free, a unique cast molding process to enhance the optical quality. It has enhanced stability across temperature gradients also. In terms of the rest of the design of the IOL, it's pretty standard. It is a hydrophobic IOL with the UV filter and blue light blocker, and it has a square edge and so on and so forth. So this is our experience with this particular IOL. When you look at the visual acuity, you look at the defocus, there's a significant improvement in the intermediate vision as compared to a monofocal. And when you compare this with the iHands IOL, the performance kind of similar. But where this lens shine is the quality of vision, where if you look at the MTF, it is really good as compared to the monofocal. And here you can see the MTF cutoff median between the three IOLs, the magnificent, iHands, and Technis. It performs really, really good. Basically, the more the number, the better the quality. So here you can see the objective scatter index, the median value which you've got is 0.5, and here you can see it and compared with the iHands and the Technis one, which is really good quality. Here, the lesser the value, the better the quality. So among all the patients we operated, 100% of the patients had unaided visual acuity of 20/20 for distance. The intermediate vision patient had 100% of the patients had 20/23 or better, and 40% of the patients had 20/25 or better. In our group, we didn't have any complaints of glare and halos. So basically, the advantage of this particular IOL is you have improved distance vision, uncorrected visual acuity, because it has a slight range, so you're a little off here and there. The patient will have a good distance vision, unaided vision. Then you also have an improved intermediate vision, which is better than a monofocal. There's no compromise in visual function, and usually there's no optical disturbances too. Now the issue is, now we have this many IOLs or presbyopic options in the market. Now how do we choose? This is not just confuse the patients, it's confused us doctors also. How do we go about this? So I usually make it very, very simple. I just categorize all these IOLs into two, make it simple, make it diffractive and refractive. Okay, so if you have a patient who's interested in presbyopic option, you say, okay, there's only two lenses, diffractive, refractive, and then you take it forward. But how do you decide which to put diffractive and which to put refractive? Here's a simple workflow. Let's say if the patient is interested in some kind of a presbyopic option, first you need to see if the patient is suitable for a diffractive IOL. Okay? So what is the criteria? It's pretty standard. You look at all these angle alphas, high order aberrations, look for any abnormality. Basically, the eye should be nice and neat before you put any kind of diffractive IOL. And let's say if it is suitable and the patient is normal, in the sense if he's not a type A personality, always asking questions, if he doesn't have unrealistic expectations, then you can go ahead with a diffractive IOL. Now, you have a scenario where he's a type A personality, he's continuously asking you, are you sure there'll be no glare and halo? Are you sure? Even though you said there is glare and halo, he keeps asking, are you sure it's not there? So if you have such a patient, it's better to go with a non-diffractive IOL. And obviously, if he's not suitable for a diffractive IOL, you simply go ahead with a refractive. This makes things so much more simpler, even decision making for the doctor and the patient. So to conclude with the magnificent IOL, it has an ultra-high optical quality. It has really good uncorrected distance visual acuity. The intermediate vision is superior to a monofocal. In terms of optical disturbance, we have not found any disturbance in terms of glare and halo as of now. But definitely it is much better than a multifocal IOL. Thank you for your time.
Thank you, Dr. Naren. One question. Regarding the pupil diameter of the patient, any particular contraindication regarding the pupil size preoperatively for this particular IOL?
These kind of IOLs, usually it's not dependent on that. It's pupil independent. But there are certain IOLs which are pupil dependent. So that's why the criteria is very, very crucial. You have to see, let's say, because it's not that you're going to put all these IOLs in your hospital list. Whichever IOLs you put in your hospital list, you have to be aware which are pupil dependent and which is not pupil dependent, and then accordingly have your criteria modified and then move forward.
I would like to share my experience with this IOL. I think it's fantastic IOL, but we have to be careful about the small pupils, because this IOL basically has high power in the center and then it goes on decreasing. So if we have a patient who possibly is going to have very small pupil post-operatively, then you have to be careful. Maybe microsphincterotomy or maybe a little bit of stretch, during which happens most of the cases, will help in the post-operative, because these patients otherwise complain of blurry distance vision, and that has been my experience. Of course, these patients are few, but sometimes what happens when surgeon starts using these IOLs and he comes across one such patient who complains of blurry distance vision and he feels that IOL is not working properly. I think.
So what is the pupil size for that patient?
I think 2 to 2.5. If it is so small, then
it's too small.
it should be at least 3 millimeter.
Yeah.
I think.
So there is a cutoff in this.
Yeah, absolutely. So
there is a pupil cutoff, is what I found, and
usually what happens is it's very abnormal to have like even scotopic, photopic. Both was so small. What was the photopic?
This was typically senile myotic patients, you know. So
then,
you have to be really.
Absolutely. I think it's better to stretch in those cases.
Yeah.
It's very rare to get such cases, but if you do, it's good to stretch it. But nonetheless, I think if it is too small, better to avoid, all the stretching and manipulation. Then it leads to prostaglandin release, and then you have increased risk of macular edema. And instead, we can just keep it simple in such cases. If it is a really abnormal case, better to avoid. Yeah.
No, the point here is that there is a pupil size cutoff for using these IOLs, 1 point, and 2, if by mistake we do put, then the result is myopic, because then the patient turns around -2 and becomes very unhappy. So, have you faced that, Saurabh?
Yeah, that's what I was.
So then what do you do?
So
do you do something to the pupil, or you?
Yeah, we can do a dilate the
Sphincterotomy.
pupil using the green laser.
Yeah.
We can just put the spots
Yeah.
and it dilates. Even YAG laser can be done.
In
Yeah,
the same,
Kamal.
sorry, in the same vein, can I just ask,
Please, ma'am.
say if you need to manipulate the pupil, then would that be a contraindication for putting EDOFs or?
It is okay, ma'am. See, the thing is, non-diffractive is still okay because it's not as sensitive as these diffractive IOLs, where let's say if there's complication because of excessive manipulation of the pupil or the iris, you can have post-operative complications, and that might affect the quality, because there is a compromise in contrast and overall light which falls on the retina when you're going with a diffractive as compared to a non-diffractive.
Because you do end up with maybe, pupillary
Sorry, ma'am?
size, you do end up when you do pupillary manipulations,
Yeah.
you do end up with a pupil size which is more than, the normal physiological. You may end up with a 4.5 or 5 millimeter pupil.
No, for those kind of pupils, it still works, ma'am. It works well, but that very rare cases where you have that small, anyway, what would happen is you would have used expanders already for those pupils. What happens on a natural basis, the pupil would have expanded. To keep that, it's not like you're going to do it for the IOL, it's just that you're done naturally for the surgery. Automatically, the pupil becomes a little larger.
I think
So
perfect. I think the mistake was that I used B-hex and not iris retractors, because B-hex doesn't cause that sphincter damage. If there was little sphincter damage, I think patient would have done better.
Yeah, absolutely.
Yeah, Kamal, you wanted
Yeah,
to say something?
Am I audible? Yeah. I think I agree with Dr. Shetty there. We used a huge number of lenses, probably 1800 plus in the last 7 months. Very happy with the lens. I agree with all of you here. But one thing for people who want to start new is don't get fooled by the autorefractometry reading. You will get a myopia.
Yeah.
True.
You will get a myopia with this.
True.
But your patient is not complaining.
Yes.
Number one. Number two, all my patients who are not dilating are the ones where I won't go for it. Even if I have a very small synomyosis, that's my only no for this. Otherwise, if even a 2 pupil, post-cat, all these pupils, the deepening of the chamber are bigger size than the pre-op. So these patients are doing well. So my no-go-to case is only where I am anticipating a floppy iris or my pre-op note says not dilated, will require rings or hooks. And otherwise this lens is performing amazingly in my hands.
Absolutely, absolutely.
Thank you.